This third lecture on cardiac failure focuses on treatment and treatment options, and we will use the pathophysiology that we discussed to help us decide what treatment might be suitable for which patient. Just to remind you that our first lecture spoke about pathophysiology and the second discussed the clinical features of heart failure. And again to remind you that our definition of heart failure is an imbalance in pump function in which cardiac output is unable to keep pace with venous return, leading to an increase in venous pressure and poor cardiac output. And this may be due to increases in preload, poor myocardial contractility, or increases in afterload. When we start thinking about treatment, there are three questions we must ask ourselves. Is blood pressure adequate? Is this mostly right or left heart failure? And is the vascular compartment in total expanded or contracted? We'll apply these questions later on. Our treatment options reflect the pathophysiology, so we can reduce the high preload. Alternatively, we can reduce the afterload and improve cardiac output. In patients with pulmonary edema, if we increase intraalveolar pressure, we might be able to dry out the lungs and improve oxygenation. And in patients in cardiogenic shock, there may be a small role for increasing myocardial contractility. So let's look at each of these four sets of drugs. The mainstay of treatment of acute left ventricular failure is reducing preload using either nitroglycerine or loop diuretics. Nitroglycerine is a powerful venodilator that can be given intravenously, transdermally, or sublingually. In all three formulations, the initial effect is to cause venodilation and reduce venous return, thus reducing preload and improving cardiac output through this mechanism. Because it's a vasodilator and is reducing venous return to the heart, it stands to reason it will cause hypotension. In certain patients, this hypotension can be dangerous. For example, patients with right ventricular infarction and poor right ventricular function, in patients on sildenafil or other long-acting vasodilators, and in patients in whom their cardiac output is severely restricted, such as patients with severe aortic stenosis. In these patients, nitroglycerine is either contraindicated or should be used with great caution. Furosemide is the loop diuretic usually used in cardiac failure, and it is considered a first-line treatment. There are two mechanisms. An early mechanism, which really is due to pulmonary vasodilation, leading to a reduced venous return to the left heart, thus improving the balance between venous return or preload and cardiac output or afterload. A late mechanism is diuresis, which reduces blood volume and therefore reduces the load on the heart. It should be noted that after all these years, furosemide has not been shown to decrease mortality in acute heart failure, although it does have some clinical benefits and is cheap and easy to use. Let's look at afterload reduction, and we're going to look at two drugs, sodium nitroprusside and ACE inhibitors. Sodium nitroprusside is a powerful vasodilator that acts both on the arterioles and the veins. In patients with severe hypertension and very high afterload, it can reduce the afterload on the heart and thus increase cardiac output. Again, this will readjust the balance between afterload and preload and therefore help treat cardiac failure in that way. Bear in mind that it is a potent vasodilator and therefore will cause hypotension and must be monitored very closely. It's often given by IV infusion, and very close monitoring must be used to make sure that its effect is optimal. Very long-term use can lead to thiocyanate toxicity due to metabolites of the drug. This is especially a problem with patients in renal failure. ACE inhibitors inhibit angiotensin 2 and bradykinin, which reduce the amount of vasoconstriction and again reduce afterload. They can be given soon after myocardial infarction, either by the IV or sublingual route, and their effects can be within 10 minutes. As expected, these drugs can cause hypotension, but an idiosyncratic side effect is angioedema. Certain drugs interact with ACE inhibitors, such as NSAIDs, which can exacerbate acute renal failure when used in conjunction with ACE inhibitors. Potassium supplements and potassium sparing diuretics, when used with ACE inhibitors, may produce hyperkalemia in the patient. In patients with acute pulmonary edema, applying positive pressure to the alveoli can alter Starling's forces and push fluid from the alveoli and from the interstitial space back into the intravascular space. Non-invasive ventilation such as CPAP and BiPAP achieve this without intubation of the patient and while allowing the patient to breathe spontaneously, and non-invasive ventilation has become a mainstay of treatment in patients with moderate to severe acute left ventricular failure and has reduced the need for intravasive positive pressure ventilation. However, if this fails, invasive ventilation may be an option, as this not only increases intraalveolar pressure and dries out the lungs, but it also gives the patient respiratory muscles a chance to rest while the heart failure settles down. These patients often don't need to be ventilated for a prolonged period of time. Finally, let's have a look at drugs that increase contractility, such as dopamine and dobutamine. Many people would prefer dopamine because dobutamine can cause inappropriate tachycardia in patients with left ventricular function, therefore increasing oxygen consumption of the ventricle. This is really reserved for patients in cardiogenic shock with poor left ventricular function, and when these patients are not responding to other treatment. But bear in mind, when we put patients on inotropes, while it does increase cardiac contractility, this also increases the work of the heart, and in particular in patients with cardiac ischemia, this can worsen the ischemia and increase oxygen consumption. So this is a little algorithm to help us decide what we want to do. We have a patient in heart failure. Ask ourselves if they are in fluid overload. If they are, so somebody who comes in with acute on chronic heart failure with biventricular failure and edema, we could consider diuretics. If not, and the patient's blood pressure is more than 90, we can try nitrates, CPAP, and vasodilators. If patients don't respond to this treatment, most do, then we may consider IPPV or positive pressure ventilation. In patients with blood pressures of less than 90, we try to get an idea of the left ventricular and diastolic pressure, sometimes clinically by determining whether the patient has pulmonary edema or not. If they don't have pulmonary edema, we can try a fluid bolus to see if we can increase the blood pressure without making the failure worse. If they do have pulmonary edema, we may need to think about inotropes. And sometimes when the inotropes increase the blood pressure, we can then consider adding vasodilators. If the patient has a poor response to this medical treatment, we may consider intra-aortic balloon pump therapy. So that was a short talk on the rationale behind different treatment choices for cardiac failure. If you have any questions, you can post them on our WhatsApp page or on the website. This brings us to the end of this short 3-lecture series on cardiac failure. In summary, when looking at treatment options for cardiac failure, we need to ask ourselves if the blood pressure is adequate, if this is mostly right or left heart failure, and is the vascular compartment expanded or contracted.